Myeloproliferative neoplasm. It is a clonal proliferation of marrow precursor cell. It contains group of chronic conditions such as polycythemia rubra vera, essential thrombocythemia, and myelofibrosis. There are mutations in the gene on chromosome number 9 and calreticulin gene, less commonly mutation in thrombopoietin receptor gene MPL. Myelofibrosis. Initially, marrow is hypercellular with excess abnormal megakaryocytes, which releases growth factors such as platelet-derived growth factor, which results in proliferation of fibroblasts. As the disease progressed, marrow becomes fibrosed. Most commonly, myelofibrosis occurs over 50 years old age people. Complaints of lassitude, weight loss, night sweats may be splenomegaly due to extramedullary hematopoiesis and painful splenic infarcts. The characteristic blood picture shows leukoerythroblastic anemia, high reticulocytes and nucleated RBCs and myelocytes. RBCs are shaped like teardrops and giant platelets. WBC varies from low to high. Platelet may be high, normal or low. Urate increases due to increased cell breakdown and folate deficiency. Strephine biopsy shows excess megakaryocytes. Treatment directed to control symptoms. Blood transfusion for anemia, folic acid for folate deficiency, cytotoxic therapy with hydroxycarbamide for control spleen size, and for young patient, hematopoietic stem cell transplantation. And we also use JAK2 inhibitor, that is ruxolitinib, for effective at reducing symptoms and spleen size. Essential thrombocythemia. Uncontrolled proliferation of megakaryocytes leads to increase in platelets count. Symptoms such as bleeding, increased platelets count. Almost 5% become acute leukemia, remaining percentage will become myelofibrosis. Management. We use low dose aspirin to decrease risk of occlusive vascular events. Low risk patients does not require treatment to reduce platelets count. High risk patients needs treatment such as we can give oral hydroxycarbamide or anagrelide or IV radioactive phosphorus in old age, interferons alpha in younger patients. Polycythemia rubra vera. Presents with incidental findings of increased PCV, increased hemoglobin and lassitude, loss of concentrations, headache, dizziness, blackouts, pruritus and epistaxis. Some patients with manifestations of peripheral arterial or cerebrovascular disease, venous thromboembolism may also occur. Diagnosis: high hematocrit, presence of JAK2 mutations. In JAK2 negative cases, high RBCs, neutrophil and high platelet count and splenomegaly. Treatment: we use aspirin to decrease risk of thrombosis and venesection. Suppression of marrow proliferation with hydroxycarbamide or interferons alpha reduces risk of vascular occlusion.